Now that we have discussed these high-yield vascular conditions in detail, we can now move on to our section on aneurysms, beginning first with the abdominal aortic aneurysm. As we begin to think about abdominal aortic aneurysms, as well as the following aneurysms in general, we can really think about these aneurysms being in three different states. We have, of course, the normal aorta. We then can proceed to having an aorta with an aneurysm, whether that aneurysm be symptomatic or asymptomatic. And then ultimately, we can have a rupture of that aneurysm. And therefore, as we think about the diagnosis, workup, and management of these aneurysms, we can really think about ourselves as stopping the progression of this disease at either of these two different points in order to ultimately prevent progression to the rupture of an aneurysm, as this can be fatal. Without further ado, let's discuss the abdominal aortic aneurysm, which is classically going to present in an older male smoker who presents with a pulsatile abdominal mass. Although this is the classic presentation that you may see on examinations, in reality this can also present as an incidental finding on imaging or from screening for AAA, as mandated by the USPSTF, also known as the United States Preventive Services Task Force. The abdominal aortic aneurysm is a balloon-like dilatation of the aorta, and this can ultimately have multiple etiologies. The most common etiology of an abdominal aortic aneurysm is hypertension, and therefore blood pressure control in patients is absolutely essential for the prevention of a variety of conditions, not the least important of which is abdominal aortic aneurysms. Additional risk factors include smoking, being a male, family history, having connective tissue disorders such as Marfan syndrome or Ehlers-Danlos, atherosclerosis, as well as alcohol consumption. As we mentioned on the previous slide, there is this USPSTF, or United States Preventive Services Task Force, and they specifically recommend a one-time ultrasound screen for men between ages 65 and 75 who have ever smoked in their lifetime. The idea here being that these men are at an increased risk of developing a AAA at some point in their lifetime, and therefore if we simply perform this one-time screening with an ultrasound, we are able to pick up on these aneurysms, as can be depicted here in this ultrasound. From this point, we are then able to follow these individuals over their lifetime with serial ultrasounds in order to make sure that we are preventing and monitoring for this progression from an aneurysm of the abdominal aorta to ultimately a rupture. And so this ultrasound screening, as mandated by the USPSTF, is absolutely essential in our ability to pick up on these AAAs early before we proceed to this stage of rupture. In addition to being used as a screening tool, we can also use ultrasound in order to diagnose AAAs. Additionally, we can also utilize a CT scan for the diagnosis of AAAs. In terms of management, one helpful starting point to remember how we manage our AAAs of different sizes is by simply knowing what we do for a AAA that is 3 centimeters in diameter, as if we have a AAA that is 3 to 3.9 centimeters in diameter, then these patients are going to need an ultrasound every 3 years. From that starting point, as we move up in the diameter of the aneurysm, then we need to increase the frequency of the ultrasounds that we are getting. Therefore, if we have a AAA with a diameter between 4 and 4.4 centimeters, then that patient is going to need an ultrasound every 2 years. And once we reach a diameter of 4.5 to 5.4 centimeters, then that patient is going to need an ultrasound every year. The reasoning behind this increasing frequency of the ultrasound, of course, being that we are trying to prevent the progression of this patient from an aneurysm that is enlarging to eventual rupture. And therefore, as the aneurysm gets larger, we need to be more concerned about the potential development of rupture, and therefore we need to increase the frequency of our ultrasounds. Ultimately, the key cutoffs that you need to know for when we actually perform surgical intervention in our patients with AAAs that are non-ruptured is as follows. If we have a male patient who has a AAA that is 5.5 centimeters in diameter, or a female patient who has a AAA that is 5 centimeters in diameter, then ultimately this is a cutoff for surgical repair. And this is extremely high yield to know for your examinations. All of this use of serial ultrasound and early intervention is to prevent this feared complication of a ruptured AAA. We should suspect that a ruptured AAA has occurred if the patient develops back pain, a tender aneurysm, a syncopal event, or hypotension. And the management in the case of a suspected AAA is going to be an emergency laparotomy. However, during this life-saving laparotomy, when we repair this AAA, there are unfortunately several high-yield complications that can occur. These include ischemic colitis, aortoenteric fistula, as well as anterior spinal artery, or ASA, syndrome. And we will now go through each of these complications in detail. First up, we have ischemic colitis, in which the patient presents with bloody diarrhea that occurs days after the AAA operation. This should not be difficult for us to imagine, because if we have our aorta pictured here and then have our mesenteric vasculature, including the SMA and the IMA, coming off of that aorta and perfusing, for example, the colon, then during the AAA repair we can get disruption of this blood flow. So if we have a patient who has a AAA repair and then presents with bloody diarrhea that occurs days after the AAA operation, then our next step in management is going to be to perform a sigmoidoscopy. And from there, if the patient has mucosal ischemia, meaning just partial thickness ischemia, then we can manage these patients conservatively with bowel rest as well as antibiotics. However, if the patient does have full thickness ischemia, then ultimately that patient is going to require bowel surgery. Ischemic colitis as a complication of AAA repair occurs days following a AAA operation. However, this is in contrast to the aortoenteric fistula, which is going to present classically with an upper GI bleed that occurs weeks to months following a AAA repair. Typically, this aortoenteric fistula is going to begin as a small or subclinical bleed that is followed by profound and life-threatening bleeding. A fistula, to review, is essentially a connection between two different tubes. In this case, it is classically between the aorta and the duodenum, and again, this is going to form over time, weeks to months following a repair of a AAA. If the patient is stable in the case of a suspected aortoenteric fistula, then we should get a CT of the abdomen, and ultimately this patient is going to require emergency surgery in order to prevent life-threatening bleeding. However, for the purposes of examinations, if you see bloody diarrhea that occurs days after a AAA operation, then you're going to want to think about ischemic colitis. But if we have an upper GI bleed that occurs weeks to months following a AAA repair, then you really want to think about an aortoenteric fistula. Our third complication of AAA repair that we need to discuss is anterior spinal artery syndrome, also known as ASA syndrome. This classically follows a gunshot or a stab wound that injures the spine and is going to result in bilateral loss of motor function, pain, and temperature. This is because the anterior spinal artery essentially supplies the anterior 2/3 of the spinal column. And therefore, as we knock out the anterior 2/3 of the spinal cord, we're going to lose motor function as well as pain and temperature on both sides, with loss of the spinothalamic tract. However, we will have preservation of the dorsolateral columns, which are located in the posterior spinal cord, and therefore we will also have preservation of vibration, proprioception, and fine touch. The pathophysiology, of course, is an injury to the anterior spinal artery, or ASA. This can also occur secondary to an embolus to the artery of Adamkiewicz. And as should now be clear at this point, ASA syndrome can also occur as a complication of AAA repair. Diagnosis is typically achieved via an MRI in order to visualize the damage to the spinal cord, and typically we can manage these patients with early immobilization of the spine, as unfortunately once this complication occurs, it is very difficult for us to regain function of the spinal cord that we have lost. And therefore conservative management is going to be the hallmark of management in these patients.